everybody. Welcome back from break. We're excited to have you back, and really just wanted to remind you that everybody is on mute. So you can do whatever you need to do during the presentation. Remember, there's also a chat box there. If you have questions specific to this presentation, certainly use that chat box. We also wanted to remind you that we have an expo hall. So if you look on your computer, up to the left-hand side where it says VCM, there's a couple little things and it'll say expo hall. So during the day, today, tomorrow, please feel free to go through there and look at what we have in the expo hall. So I'm very excited to be able to announce Dr. Gafni. She received her BA from the Barnard College and her MD from Temple University. She completed a pediatric residency at the Children's Hospital of Philadelphia, followed by a pediatric endocrinology fellowship at NIH, serving as an officer in public health service. She subsequently served as an assistant professor at the University of Maryland. Sorry, my tongue is tied today. Dr. Gafni returned to NIH in 2007 as a staff clinician in the National Institute Dental and Craniofacial Research. She is also a faculty member in the NIH Pediatric Endocrinology and NIH Inter-Institute Adult Endocrinology Training Programs. She is an investigator on several protocols studying and treating patients with endocrine disorders, including hypoparathyroidism and other metabolic bone diseases. We're very excited and we're grateful to Dr. Gafni. So please join me in welcoming Dr. Gafni.
Thanks so much for this introduction. Can you hear me okay?
Yes.
Sounds okay? Great, good. So I think the last time I was with you guys was a couple years ago in Jacksonville, and it's so wonderful that so many people can participate because we're doing this virtually, but I do miss seeing all of you in person and getting the opportunity to sit at the tables and talk with people and have lunch together and really hear all of your stories and sometimes answer some of your questions. But I'm just going to give you a little bit of an update on what's been going on at the NIH. These are my disclosures. We do receive research support from Calcilytics for one of our clinical trials. And this is the outline of what I'm going to talk about. Briefly, I'm going to focus on just a very brief review of parathyroid hormone, since everybody here pretty much knows a lot about that, and also talk about the calcium sensing receptor, and then go into details on the disorder called autosomal dominant hypocalcemia. And then at the end, I'm very briefly going to mention another study at NIH that's being done by a different investigator on autoimmune polyglandular syndrome. So this is the quickie review, and I honestly don't know how many people are out there, and I know for some of you everybody knows this really, really well, and for others of you this is kind of new, and it's always good to hear it multiple times to really solidify the information. But parathyroid hormone is very important in regulating calcium levels in the blood and keeping it within a very tight, narrow, normal range. So when the blood calcium level drops, parathyroid hormone is released by the parathyroid gland, and then it goes to different parts of the body to increase the blood calcium. It goes to the bone and causes bone breakdown which allows calcium to be released into the bloodstream. It also goes in the kidney and causes calcium to be reabsorbed back into the bloodstream. So less calcium will go out into the urine. And also in the kidney, parathyroid hormone increases the production of calcitriol, which is the body's form of active vitamin D, which then acts at the intestine to increase the absorption of calcium from the food. And these three main actions of parathyroid hormone lead to an increase in the concentration of calcium in the blood. More specifically, what are some of PTH's actions on the kidneys? Well, I mentioned one is that it increases the production of calcitriol, but it also increases the reabsorption of phosphorus. So less phosphorus, it promotes phosphate loss. So parathyroid hormone causes you to lose phosphorus in the urine, and it also allows you to increase your calcitriol levels, in addition to reducing blood, increasing blood calcium by reducing urinary calcium. So overall, when you don't have enough PTH because you have hypoparathyroidism, what does that mean? So you can't pull calcium out of the bone. You can't reabsorb calcium from the urine, so you lose calcium that you need in the urine. You can't make the active form of vitamin D to absorb calcium from your food, and you can't excrete phosphorus into the urine. So you end up having high blood phosphate. When the blood calcium goes down, the blood phosphorus goes up, and the urine calcium is inappropriately normal or frankly high. And that particularly happens with treatment. So, oops, my thing is not advancing there. So how do the parathyroid glands and the kidneys know how much calcium is circulating in the blood to make all of these adjustments to keep the calcium in this normal range? So the calcium sensing receptor, which is abbreviated here CASR, controls parathyroid hormone release. So this is a picture of well, it's not really a picture, it's just an oval, but it's supposed to represent a parathyroid cell. And here you can see, oops, where did my pointer go? Let's see. I seem to, there it is. Okay, let's try a different pointer. Let's use a laser pointer. Okay, so this is the calcium sensing receptor, and it's a very complicated receptor that sits on the cell surface. And the normal calcium levels, as you all know, is between 8.5 and 10.5 milligrams per deciliter. And when the calcium sensing receptor is in the inactive state, because there's not enough calcium around, parathyroid hormone is produced and released throughout the cell. So the calcium sensing receptor works like a thermostat. So here you have your thermostat, it's set at 70 degrees. It's detecting that the air around the thermostat is 70 degrees, and your heater is just sort of in a steady state. But if the temperature drops down to 68, then the thermostat signals to the heater that it needs to release heat, and the radiator starts working to bring the temperature back up to 70 degrees. So when the blood calcium is low, the calcium sensing receptor is turned off and parathyroid hormone production increases. So you have more parathyroid being released into the bloodstream. Conversely, when the calcium level is high, the calcium sensing receptor is very active because all of this calcium is binding to it, and PTH production decreases. Sorry, for some reason, my advancing isn't working that well. Okay, so similarly, there's calcium sensing receptors not just in the parathyroid gland, but also throughout the kidney. And the same thing happens when calcium is sensed by these calcium sensing receptors in the kidney. The calcium sensing receptor tells the kidney there's too much calcium around and you need to get rid of the excess calcium by putting it out into the urine. So let's turn to one of the genetic causes of hypoparathyroidism called autosomal dominant hypocalcemia type 1, or ADH1. And this is a rare genetic form of hypoparathyroidism. And how frequently this disorder is seen is uncertain, but it's estimated to be about 1 in 70,000 people. And what happens is that there's a change in the gene that makes the calcium sensing receptor, and this change causes it to be stuck in the activated state. And when the calcium sensing receptor is always activated, always turned on, it tricks the body into thinking that the blood level of calcium is higher than it really is. So imagine it's freezing in your house, it's the dead of winter, and you have your thermostat set to 70 degrees, but the thermostat thinks that it's 80 degrees in your house. And no matter what you do, the heat just won't turn on. And that's what it's like to have an activating change in your calcium sensing receptor. Your calcium goes low, but the parathyroids don't turn on. So this is what you see here. Here we have our parathyroid cell. Now you have these little green balls here represent this activated change of the calcium sensing receptor. And even though the blood calcium is low, no parathyroid hormone or very little parathyroid hormone is being made. And this happens in the kidney as well. So even though the blood calcium level is low, the kidney is being tricked into thinking that the blood calcium is high and causing a lot of calcium to be released into the urine when it really needs to be reabsorbed back into the bloodstream. So this disorder, autosomal dominant hypocalcemia type 1, is similar in a lot of ways to other types of hypoparathyroidism. Patients have low blood calcium and high blood phosphorus. They can have inappropriately low or normal parathyroid concentrations. So some patients have PTH levels in the low normal range, but it's not enough. It's not high enough to prevent hypocalcemia. This is an isolated form of hypoparathyroidism. It's not part of a larger syndrome, and the patients typically have normal growth and development. And the severity is really variable. It ranges from seizures in the infancy period to asymptomatic patients with very mild to moderate hypocalcemia. And it's not that uncommon. And I'm a pediatric endocrinologist where we make a diagnosis in a baby, and then we check one of the parents and discover that the parent has slightly low calcium and never realized it their entire life and thought, oh, well, that's why I always have light cramping in my hands or my feet, or I get some tingling around my faces. I never knew that was why, that my calcium was low. Patients can have high urine calcium, sometimes much higher than patients with other forms of hypoparathyroidism. And this can lead to calcium deposits in the kidneys and even decreased kidney function. And patients often also have low blood magnesium because the calcium sensing receptor has to regulate magnesium levels as well. So what do we mean when we call a disorder autosomal dominant? This is autosomal dominant hypocalcemia. And I apologize to those of you who are really into biology and genetics, but for those of you who are less familiar with chromosomes, I'm just going to give a really brief review about this. This is the chromosomes the average person has. And when we say autosomes, those are the chromosomes that do not determine one's genetic sex. So most people have 22 pairs of autosomes and then one pair of sex chromosomes. The sex chromosomes are either the XX for women or the XY for male. And then the other 22 pairs are the autosomes. So autosome is just another word for non-sex chromosome. For each pair of chromosomes that you have, you get one of them from your mother and one from father. And the changes that occur in genes on autosomes usually affect men and women equally. And that's different from the sex chromosomes. You think some disorders are what we call X-linked or sex-linked and happen more commonly, for example, in men, like colorblindness is an X-linked or a sex-linked disorder. And that's because those chromosomes are not exactly the same in men as in women. And the gene for the calcium sensing receptor is located on chromosome number 3. So now that's what autosomal means. So what does dominant mean? And here you have a picture of the parents here, and the purple mark on that autosome is the change in the calcium sensing receptor gene. And you can see here that the father in purple has that change in his gene and he is affected. So in dominant disorders, only one copy of the gene needs to be changed to have the condition. Other disorders, you have to have 2 copies, one on each of the autosomes on each of the pairs in the pair to have a change. For example, an autosomal recessive disorder is something like sickle cell disease or cystic fibrosis, where you have to have a change on both copies of the gene. But in an autosomal dominant disorder, you only have to have a change on one copy of the gene. And when it's dominant that way, there's a 50-50 chance of having it to a child with each pregnancy. So you can see below possible combinations. You can have 50% will have it because they'll get the one with the copy with the gene from the father, and 50% won't have it because they will get the unaffected chromosome from the father. the thing to remember that it's not like if you have 10 kids, 5 will have it and 5 won't. It's 50-50 with every single pregnancy. So you could have 10 kids and they could all get affected, or you could have 10 kids and none of them would be affected. The 50-50 chance is every time you have a pregnancy. And the other thing to remember is that it's not uncommon for autosomal dominant disorders to occur sporadically, which means you might be the first person in your family to have it. Yeah, can you hear me?
Yeah, excuse me, Dr. Gafni, we're having some issues with the audio. We're having some issues with the audio. I don't know if it's on your end or if it's or whatnot. I know tech is kind of looking into it, but they
hear you now.
Dr.
I'm getting a message that my network is causing a poor quality call, but I'm on an Ethernet line. I can try to switch my Ethernet to a different. Let me just try to switch so that I'm on a better Wi-Fi for a second, because I am getting some weird thing here. I did restart my computer right before just to make sure everything would be working, and I came into work rather than doing that from home, thinking this would be best. But let me switch to a different Wi-Fi connection. Have you heard anything I've said, or have I been talking to myself?
No, we've heard you, Dr. It was just recently where it got a bit choppy. That's when we cut you off, so no problem at all.
Okay, let me just see if I can switch so that I have both Wi-Fi and a LAN. And that way, I don't know, something squirrely is happening with my, I specifically came into work because I thought this was more reliable than doing it from home. But, you know, this is the government. I'm the mercy of the government computer here. I don't know what's going on. My Wi-Fi is just completely projecting. Me switching. I don't know. Should I try to keep going, or what do you want? Let me switch.
Everyone, we're just going to do our best to help her as much as we can with her audio. So if you just be patient for just another minute, please, that would be amazing. Just one more minute and we'll see what we can do. Thank you.
Is that better now? Is that better now? Can you hear me? Can you, oh, wait, can you hear me now?
Yeah, we can hear you. It's just very slow and a little choppy.
Okay, I switched to a different LAN, but I'm not really sure what's going on with my wireless thing is sort of frozen here. I don't know what's, I feel like it's something with my computer. I'm not really sure. Should I keep trying? Should I keep it?
Dr. Gafni, do you think maybe it would help if
How's that? How's that? Am I? I should have stayed at home.
Amanda, did you maybe
I'm terrible about this.
her taking
This.
Dr. Gafni, I think
Yeah.
what we could do, okay with you, is maybe we have you could record.
Oh wait, I think. Hold on. I think my. Hold on. Let me just make sure I'm connected. See if I can switch this. Okay, I'm definitely connected through the Ethernet. Is that any better now? Through a different Ethernet.
It's still
source.
very choppy. What I think I could
Not
do,
good.
Dr. Gafni, is if you could hear me, I think the best solution, if it's okay with you, I spoke to Deb, is if maybe we have you record your presentation separately, maybe like at home or another room, and we're uploading all of the recordings to the website, and then within a week or so, and maybe if it doesn't work, we can at least that could be a good option so that everybody can hear your presentation.
How's this now? I just switched to a different Wi-Fi connection. Is that better?
Can you speak again so I can hear?
Yeah, is that any better? I switched to a different Wi-Fi connection.
Unfortunately, no, it's still choppy.
This is so frustrating because I came on campus so that I would have, like, I don't know what's gone. My computer is just doing something weird. I mean, I can do that. If I turn off my video, it'll be better. There's a bandwidth when I do that. Is that any better?
No, the audio, it's just the audio, because you know what, your connection, I can see your slides, and when you're moving, it's just the audio that's very choppy.
The strange thing about the slides is I'm seeing like this sort of flickering around the shared screen, and I haven't experienced that before. I can record it, it's fine. I don't mind doing that. I feel like, has it gotten any better? I'm terribly sorry, guys.
No, it's fine. It happens. We could get on and ask the population if they have any other questions or they want anything, and we'll send them to you as well.
Well, I wanted to tell them about the study that we're doing, and
Yeah.
I haven't told them about any of the studies. I'm still sort of in the
So Amanda,
introductory thing, but do you want me to try and see how the sound is? Is it better now?
Amanda, is there any way that
you know, why don't I turn my headset to?
Dr. Gafni, my one other suggestion is if you were on a headset, what if you just didn't use the headset?
Yeah, that's what I'm doing. I'm turning off the. Is that any better?
No, unfortunately.
You could try and
Yeah.
just try and disconnect from your network and then reconnect.
I did because I switched landlines. I did connect, and I had to reconnect to Teams. Is that any better?
Okay.
Switch to a third microphone.
it's getting a little bit better? We can at least clear.
I mean, I don't know what I could try. I had just restarted my computer right before this because my computer was doing something weird. So I'm not really sure what the problem is.
Yeah, Rachel, seems like it probably is at the computer. What to Bob's, get everybody's questions. Wanted to ask, worst case, you can record it once uploaded, but I'll leave this to Bob. What would you like us to do?
Yeah, Copy there too. I don't know if that's my connection.
Do you want me to like shut down Teams and try to restart Teams?
Well, we got, there's 5 minutes left, right, in the presentation.
I mean, if you want, I could jump ahead to just the last couple slides about the study, and then just try to take questions from that.
Okay, we could try that. If you want to try and exit Teams and then log back in.
Or I could also try closing PowerPoint and reopening it, because I don't know if or stop sharing for a second and reshare, because I don't know why my share screen is like flickering so much. Let me stop sharing and reshare. Is that okay if I do that for a second? Okay. Yeah, so is it better now that I'm not sharing my screen? Or no?
Yeah, absolutely.
Yeah, so maybe it has something to do with PowerPoint. There, now it's not flickering anymore. Is that better?
Keep talking. Keep talking.
Okay, that's my microphone is muted. Can you hear me now? Is that better? Let me check my.
Rachel, you know what else you could do as well? It's a good option is if you just leave this set, you could just leave this and you could join back in queue and this control from here. Why don't we try that?
You want me to disconnect from Teams?
Yeah, like you could leave this session, we could stay here and wait, and you could join back in as well and see if that works.
Okay. All right. Yeah. Okay.
Okay, I'm going to do the same thing real quick too.
I'm back. How's my sound? How's still not good?
It's slow. Keep talking a little bit.
Okay. How's that?
That's a lot better.
A little bit better.
Okay. Let's try and go with it. My screen is not quivering. Can everybody hear me again?
Yeah, I think if you just did it without the slide, maybe, then that way we can hear good. Maybe.
Yeah. So can you not hear me now?
Now it's starting to do it again.
All right. My computer is just trying to, I don't know what it's trying to do. Anyway, I guess I will stop sharing and I will just talk then. Okay. So I'll at least put my camera on so you guys can see me, and I'll just take a look at my slides so I know what I was going to tell you guys. But so we were talking about autosomal dominant hypoparathyroidism or autosomal dominant hypocalcemia, which is due to a change in the calcium receptor, where it's turned on all the time and it's tricking the body into thinking that there's more calcium around there is. Can you guys hear me?
It's starting to break up again. I'm so sorry. We really wanted to be able to hear you today. It started out really good.
Really sorry. I don't know. This is, I don't know what's going on. That's the NIH. I guess I'll just record it. And, you know, unless, if you want me to try to do it tomorrow, I can try to do it tomorrow from home. If there's time, I can do it during a break or lunch or whatever.
Okay, let's so we will get back to you. I'll talk to Deb and everybody and see what we can work out, and potentially we could do that because your information is extremely valuable to all of us. So, but at this point, I think we'll go ahead and call a break for the group that's online, and then we'll come back and with the next session at
3:15.
3:30. 3:30 Eastern time. Sorry, 12:30. When isn't it?
3:30. It's
3:30. Excuse me. Eastern time. Yes. So thank you so much. We'll talk to you in just a little bit to see if we're able to figure it out for tomorrow. And for everybody out there, we're going to have a little bit of an extended break until the 3:30 time frame, and then we'll get started with our next session. Thanks, everybody.